is intelligence quotient rise regularly occurring with an intensive interpersonal treatment. The interpersonal treatment is called reflective network therapy. It is aimed at preschoolers on the autism spectrum or with other emotional disturbances requiring special education in ages 2 to 6 years. This method is of interest neuroscientifically because of the regularity with which the Wechsler preschool scale of intelligence rises. First, let me tell you about the method, and then let me tell you about the results. I doubt that time will permit for me to show videotapes of the treatments, but you may write to me and I can send you a flash drive with parent-permitted video recordings. My email is Gilbert Kliman, Kliman, 2008 @gmail.com. First, what is the method called reflective network therapy? It is a technique used with preschoolers right in their classroom and only in their classroom. There is no pulling out for psychotherapy. All the psychotherapy takes place in a preschool settings. There are a handful of steps in applying reflective network therapy. First, the children are assembled into regular preschool activities. A therapist or psychoanalyst, it may be either a psychodynamic therapist or a child analyst, enters the classroom after activities are already underway. Before the therapist has entered, parents have come in and dropped off their children. Parents are permitted to stay and often do during the opening weeks of a preschool. The parents brief the teacher in a short communication as they drop off the child. So at the beginning of the day, the teacher already knows something about what the child has been doing, feeling, and what is going on in the family. The teacher has the task of briefing the therapist when the therapist comes in to work with the 6 or 8 or 10 children that may be her patients or his patients in the classroom. This briefing takes only 2 or 3 minutes, during which time the teacher passes on observations she has made as well as information she has acquired from the parent. Then the child therapist has an individualized psychotherapy session for the first child right in the classroom. This play therapy session is very much the same as would occur in a private playroom, but it is entirely taking place in the public space of the preschool. After 15 or 20 minutes, the play therapy session is ended, and the child and therapist brief the teacher about what they have been doing. The therapist may provide some interpretations during the play therapy sessions, and he may repeat them to the teacher. The child may correct or amplify what the therapist says during the several minutes debriefing. Other children have been watching the play therapy session, and they may add to the debriefing. For example, a child may say, "You forgot to say that Johnny broke my block building." After this first segment of treatment, the teacher, analyst, and next child go on to have another briefing, play therapy session, debriefing. So during the course of a morning, many children may be treated. Parents are frequently observing, sitting in the classroom. Every week, the teacher meets with each parent for about 45 minutes, and once a month, the psychotherapist meets with parents, doing not only guidance, but sharing information. Thus, as you may see, there is a very information-rich network set up. In fact, the preschool classroom is a uniquely psychodynamically informative instrument in a network form. Unlike pull-out therapy, in which a child is removed, reflective network therapy is deeply integrated into the child's learning space as an interactive social setting is present in the preschool. Everything takes place therapeutically within the learning and play activities of the classroom and the early educational process within the classroom group. These processes are usually video recorded. There is usually a volunteer or paid videographer who samples or may make a total document of the process. We have many thousands of such permitted parent video recordings. Every week, the team meets and they often deeply study several videotapes during their weekly conference. Every day, the team has the advantage of many opportunities to consider immediate evidence of the child's emotional, behavioral, and cognitive deficits, strengths, and symptomatology. Indicators of distress, enactments of trauma, impending crises, conflicts, resistance, and transference are therapeutically addressed by the child therapist when they occur. Each child coming every day will have 4 or 5 sessions a week for 40 or 50 weeks a year, thus involving usually about 160 psychotherapy sessions a year. This method has been applied to about 2,000 children in 30 different sites all over North and South America. It has regularly produced rapid mental health gains, positive behavioral changes, improved relational skills, and substantially expanded learning capacity. I would like to turn now to some data which indicates why I think it is worth the trouble of carrying out this method. And one set of data is a Wechsler preschool scale of intelligence. I'm trying to call up a chart now, and I'm going to share my screen, which I hope you can see. Can you see that screen?
Yes, Doctor, we can see your slide.
Thank you. Here is a meta-analysis of 10 projects which had psychologists performing Wechsler preschool scales of intelligence and providing full-scale IQs on a total of 81 preschoolers who were tested at the beginning and after at least 8 months of treatment in the reflective network therapy program. These 10 projects were widely separated geographically. Some were in New York, some Washington State, some Oklahoma, some Buenos Aires, others in a Native American tribe north of Seattle, some in a public school in San Mateo, California, others in a private preschool where there was a mix of neurotypical and disturbed patients. About 40% of the patients were on the autism spectrum, and others had post-traumatic stress disorder, anxiety disorder, or conduct disorders. Many of the children had been uncontainable in previous schools and were referred because they could not be schooled in regular settings. The average gain of full-scale IQ for the 81 children was 15 points, a very significant rise, and some of the children had extraordinary rises. One followed in Oklahoma had an 80-point rise and was followed for 50 years. I should mention that I invented this method and have been following it and researching it with the help of third parties and various grants for about 47 years. Some of our follow-ups indicate that there is a sleeper effect. So a number of the children followed have had continuing rise of IQ, some to an extraordinary extent. On the website of the Children's Psychological Health Center, you will see a 33-year follow-up of an autistic child who was mute, whirling, twirling, hiding in a corner, and untestable for almost a year, at which point she had an 80 on the WIPSI. But her IQ kept rising by age 6, 10, and 12, So it rose finally to 129, a 49-point rise. Other children we know now who were very unsuccessful are pursuing very complex careers and apparently have experienced the sleeper effect. Let me show you, if I can, a little more data. And interesting to me is what I think of as a dose-related effect. So here, I hope you can see that. Can you see it?
Yes, doctor, it's clear.
Thank you. Notice some of the projects had small frequency of the therapist in the classroom, but other projects had very large frequency and quantity of sessions by the therapist. There was an orderly relationship between the dose and the outcome on full scale intelligence. Now, I think I only have 10 minutes left. So I'm just going to audaciously try to show you some brief moments in the classroom. If I can activate my video method, my video recording, it does take a minute. It comes in from the cloud. And what I would like to show you is some moments first with a fairly high-level autistic boy who came in with an IQ of about 98, an Asperger's boy, we thought of him at the time. He was screaming, howling. He couldn't be contained in 6 other schools because of his aggressive and noisy behavior. He would recite railroad tables as if the railroad schedules were of great interest to others, even strangers. And here, fortunately, we finally have, I hope you can see that, can you? Can you begin to see my screen?
Not yet.
Not yet, I'm sorry. Well, I have to do a few things to make that happen. And I think you can see.
Yes, it's all right.
I think I have to do some other things to allow you to hear in this particular, well, I don't think I can do that. So I'm just going to show you silently here's a video of a public school special classroom in which I have about 10 patients. This boy has Asperger's syndrome and he's in a fire hat. At some point, he's screaming and kicking, and he's given a timeout under a table. And this handsome fellow here with the bald head is me. I'm about to enter a space where the child has set up his timeout, and I will, I receive a briefing from the teacher. A behavioral aide has accompanied the child at the beginning of his entry into school, but she is no longer needed. Now, what I am doing is I'm singing to the child. his mother has told me that he is soothed by singing. And although my own children would pay me not to sing, this child is actually quieted by my singing, and we have a conversation, a dialogue under the table. Ultimately, this child became a scientist, doing quantitative genomics at a very advanced university, and set up an organization of or a network, really, of other scientific projects. Now, in the same classroom is a, notice here the mirroring of the child. He identifies with and mirrors my movements as we watch and speak and observe about other children's behaviors. There's another child in this class who has just had a terrible traumatic experience. He enters, you can see his mother leaving. His mother has been scolded by the father, and the child is a percipient witness to this. So here's the mother's scalded face, and the
Dr. Kliman, we can't see your video or screen yet.
You cannot. Well, I'm glad you told me. Thank you for speaking.
Yes, I thought you know. Yeah.
Well, I apologize. I think it shows screen.
It's okay. Now we can see. Yeah.
All right. Well, that's very sad, but at any rate, here is the boy I'm working with under the table and singing to, and here we can see him identifying with my gaze. Looks like a mirror neuron coupling, and here is a second child showing the treatment of traumatic disorder. And the child falls dead, as if dead, after he enters the classroom, and later builds very shaky blocks, cleans up the kitchen, and manifests some transference phenomena. By looking at pictures of me and him with other children. So we talk about how he is happy to have a classroom family when his own family is very shaky. He builds shaky buildings, and we discuss the shaky buildings. I block talk with him about how this is like a family that is falling apart. So I make an interpretation, and he begins to speak more coherently, comprehensively, and ultimately has an extraordinary rise of IQ, 31 points. Now I'm going to stop the share and hope that you can see me now. I don't see myself too well, but that's all right. What I'd like to do is to pause for questions and discussion, because this is an unusual, a rather unique form of interpersonal treatment carried out by 30 different teams, at least, throughout the world, and showing a kind of evidence that is not usually sought in psychodynamic therapy, and that is IQ changes. None of 63 control and comparison children had IQ rise. In fact, on average, they had a very slight decline of IQ, in keeping with what we know about traumatized children, especially. Well, that's an awful lot for you to absorb in 20 minutes. So I would welcome some reactions and discussion. Thank you very much for inviting me and for your attention. Who would like to speak or question?
Thank you so much. That was amazing. I do respect it.